time it was also on video, wasn't it?
Yeah. Hopefully that we can meet in a better conditions.
Yeah, I really hope so. In the beginning,
but
of
I don't think
year.
so. It will take some time.
Yeah, it will take some time, obviously. Yeah. Yeah.
Okay. Yeah. Should we start now, or
I think so. Yes.
Yeah, you can start now. So, can we see the students now, or how does it work?
Yeah, I think more and more students are opening their videos.
Yeah. Yeah, you can.
Hello, teman-teman.
You can open your videos now.
Hello, sir.
Maybe that's a bit awkward because we were talking about something else, but you can now open your videos and we can start the lecture. Okay. So we're very happy to have Professor Dick Willems with us here now, there. Yeah, so I will introduce a little bit about Professor Dick Willems. He's a professor of medical ethics from the Amsterdam University Medical Centers in Amsterdam. He's also a chair of the Healthcare Ethics Committee, right, Dick? Are you still the chair of Healthcare Ethics Committee at the AMC? The Academic Medical Center is the hospital for the University Medical Center. And then he's also a member of the Research Ethics Committee of the Academic Medical Center, or is it for both hospitals?
No. That's just for the one hospital. Still, it will be for the both. Yeah.
Okay. And you are also a member or something in the Amsterdam Public Health Research Institute.
Yeah. I was the chair of the personalized medicine program.
Oh, okay.
The co-chair, one of the chairs. But now I'm just a member again.
Okay, that's good. Yeah, and Dick has been here quite a lot of times, I think. How many times, Dick? Have you counted?
I think 11 or 12. I'm not sure. Something like that.
Really? Yeah.
Between 10 and 12, somewhere.
Yeah, and I don't know if some of you have met him, but yeah, he has been here, and you've been to, I don't know, many places here in Gunung Slamet also to the volcano.
Sure, of course, yeah.
Okay. Oh, Pak Fitranto, I see Dr. Fitranto, our former dean. Pak Fitranto,
okay.
Are you there? I saw you. Okay, and okay. Hi, Pak Fit.
Hi. Hi, Prof.
Oh, hello. Hi. Nice to see you again. Really nice. Yeah. And you have lockdown on your T-shirt. That's interesting.
Oh, that's a nice T-shirt.
We hope to avoid the lockdown here again. But yeah.
Actually, many people here hope to get to be in lockdown, Dick.
No, some people still hope to. Yeah, I see.
Okay. So it's nice to have you here with us, Pak Fitranto. And there's also, I see Pak Yudi also, our former vice dean. I don't know if we can see him, but I see him here. Anyway, welcome to also the lecturers who are with us this afternoon. Okay, so for the lecture, Dick, I think will be giving a presentation for, I don't know, 45 minutes, Dick, or maybe, or something.
Something like that, yes. Yeah. We'll see.
I see. We will have the questions later, but I think also, Dick, you like to ask questions in between, so you can also do that. They are used to that method with us in bioethics, so I also give my lecture and ask questions to them in between. You can also type your questions in English or Bahasa Indonesia, and we will help you translate it in English. By the way, Dick, this morning we had a lecture with Daryl Maser.
Oh, is that true?
Yeah, but it's another. Yeah, it was not very nice. So the time difference is 14 hours, so it's easier for.
With him.
Yes.
Oh yes.
Hours, so it was.
He's in the States. He's in the States, of course.
California. Yeah. But this was another group of students, so so we also did that Q&A, both written or orally.
I see.
So it's quite flexible. Whatever you want to do.
Yeah, whatever the students prefer. So I don't mind which way.
Okay.
But for the Q&As, I will need you to either translate or to keep track of the Q&As, and
Yes,
and
sure.
then you can ask me to answer a question if it's related to what I'm speaking about at that moment.
Okay,
So,
sure.
So I'm happy to be interrupted, really, by
Yeah.
you or by the students, and I'll even ask students things during the lecture. So we'll see.
Yeah, yeah. And I think students are also already used to that. And I know that from my experience, they're quite active.
Good.
But this morning they were a bit quiet with another, I think they're a bit shy with someone they haven't met yet. But I hope for this class, you are not shy. So you can still be active as usual in our classes. Okay, so Dick, I give the time to you.
Good. So I'll then share my screen, I think, because I have a PowerPoint presentation, and so let me see which one it is then. Oh, this is it, I think. I'll have to start the sharing and ask you if you see. So that's the end. So we'll come there at some point.
Mm-hmm.
But I'm going to try to start at the beginning, which is also always a good idea. So, so can you see my presentation?
Yes, we can see your presentation.
So it's full screen now, isn't it? Yeah,
Yes.
for me at least, it's
Yes.
full screen. And I can still see some of you, which is very nice, because I sometimes give lectures in Amsterdam through online lectures, and then I see really nobody, which is strange. So, well, I'm really happy to be able to give this lecture in your bioethics block. I'm really happy to do that, even though I really regret that we have to do it this way, because I have very good memories of lectures at UNSUD in physical circumstances, let's say, and I remember that the audience usually was really active, and I would really ask you, the students, to ask any question you want. There's no stupid questions, and there's no question that is not appropriate. You can ask anything you want. And especially because we have to do it online, I hear from students here that it's very difficult to sit and watch for 3/4 of an hour and not do anything. So I'll ask you some questions about cases that I have, but please interrupt through Q&A or just switch on your microphone and ask a question. And there's no reason at all to be shy, that in any case. So maybe for my background, I've also been working as a doctor. It's been a while now, because I'm a full-time professor of medical ethics now in Amsterdam. But I've been working as a general practitioner for about a bit more than 15 years in Holland. So I have some medical experience as well. So I'd like to start, and what I've done is I will discuss briefly 5 areas of ethical issues related to COVID-19. And after each of these areas, I'll briefly stop to ask if you have any questions, to let you, maybe we can have some discussions, because they're all a little bit different, these ethical issues. So I can easily cut the whole thing into smaller parts, which in this context may be better than just rushing on. So what I will be speaking about is distancing, because as we all know, we have to live at a distance from each other, and there are ethical issues related to distancing and to the practice of keeping a distance. Then there's another issue which is quite different, which is what we call the crowding out of non-COVID care, which means that patients who didn't have COVID during the first big wave of COVID-19, have received less care or no care at all. And that's an ethical issue. So I'll get back to that. And then maybe the largest part will be on shortages of all sorts, but the main part will probably be on how do you select patients when there is a shortage of hospital beds or a shortage of intensive care unit beds. Then the care for professionals is one of the ethical issues. It's a smaller one maybe. And if we have time, I think there are also questions that have to do with research under emergency conditions, such as a COVID epidemic. So those are the 5 areas I'd like to speak about. Is it still, am I still, can you still hear me? And
Yes,
is
we
it
can.
difficult?
Yes.
All right, and can you follow me? If I speak too quickly, if any of the students finds that I speak too quickly, please ask through the Q&A that I speak more slowly, because there's I sometimes go a bit fast, and that's no use, I think.
Okay, thank you.
Yeah, and there's another thing that I should have said in the beginning. I was at a webinar last week, and then the connection broke down on my side, not on the Indonesian side, but on the Dutch side. So if anything like that happens, I'll get in touch with the staff through WhatsApp, and then I'll be away for about 2 minutes, because all I have to do is reset my router. Hopefully it doesn't happen, but don't panic. I'll be back in a few minutes if the connection breaks down. Okay. So that's, I think, so I'll like to start with the oh yes, the first thing I want to say is that what is, in fact, the main thing that makes COVID-19 and other pandemics so special is that we change a paradigm. So we look at ethical issues from a wholly different perspective. And I think the easiest way to explain that is that we go from an individual focus on individual patients and what is the best care for them and what's good for them, to a more utilitarian focus. And what that means, it's a complicated word. You don't even have to remember that, but the change in paradigm is that we go from what is best for each individual patient to what is best for most patients. So we're not only looking at what is best for patient X, but we're also looking at what is best for the whole population. And it sometimes means that the interest of the individual patients are, well, let's say, sacrificed for what is best for the population. And this, I think you should realize, and I'll come back to it at some points in the lecture, this is at least in tension with the Hippocratic Oath, because the Hippocratic Oath and most ethics codes, the ethics codes also, I think, of the Indonesian Ethics Medical Association, but certainly also the Dutch Medical Association, in that ethics code, the paramount interest is the care for the individual patient. So we're really moving to something that is, and I mention this because in conversations with doctors about the ethical issues, this is really their main problem, that they sometimes have to look at the group and not at the individual. And doctors are not used to them, and they feel that it is sometimes unethical to do so. So that's the cause of a lot of what we call moral distress. So distress about ethical issues. I'll get back to moral distress at the end of the lecture. So this is really something that you have to keep in mind. And if there's something you have to, or I hope you get from this lecture, is that it's a switch from individual to population ethics or to utilitarian ethics. Are there any questions up to now? Because I can't see the Q&A now because I'm on full screen. If there's no questions, I'll just go on.
Okay, go on.
So I'll start with, yes, right, good. I'll start with the first, the ethics of distancing. And I'll just give you some examples of why that may lead to ethical issues. So the first form of distancing that took place in April and May of this year in Holland, when we had the first big wave of COVID infection, was that it was decided that elderly people, especially those living in nursing homes and in care homes, had to be isolated to protect them from the virus, because they were considered, rightfully, I think, I mean, it's true, they're the more vulnerable people. And also those who have cognitive or physical impairments. And the reason why, well, this was very hard for those people, because they had to spend several weeks in complete solitude without seeing anybody except the people in the nursing home or the others, but not their families. So I have a case a little bit further on to speak about this, but this is something that has aroused also a lot of public opposition, because people thought it was unethical to lock up elderly people who already had a lot of impairments, and then also lock them up. And the same applied to people with cognitive impairments. I happen to have a brother who has Down syndrome, and he's living in a special form of home. And in the beginning of the epidemics, it was clear that we could not come to visit him, and he could not come to visit us as a family, because he has 7 brothers and sisters, so he goes to all of them from time to time. And that was stopped in April. And that was really hard for him, because he loved those meetings with his brothers and sisters. And we had to communicate in other ways. So that, I think, was the first ethical issue. I have a case that's a real case that really happened, of a woman who was 85 years old, who lives in a nursing home, so in a special care home, because she has Alzheimer's disease, not very seriously, but she's forgetting things, and she couldn't live on her own anymore because of the Alzheimer's. And then in Holland, many people with Alzheimer's disease live in nursing homes. She also has various physical complaints. She couldn't move around without help. She can't move around without help, and she's not able to cook her own meals and things like that. And she has also respiratory complaints. So there's quite a lot of things going on with her. And before the corona epidemics, she was visited 2 to 3 times per week by a son and a daughter. And then the whole nursing home was locked. So the whole nursing home went into quarantine, into lockdown. So there were no more visits. And Mrs. A then complains that she's increasingly lonely. She feels horrible. She sometimes says that she would rather be dead than live on in this way, because it's useless, and she's very sad, really, about not being able, only seeing her son and daughter through iPad connections, the type of connections that we have now. But for someone with Alzheimer who's already impaired, that's more difficult, and it's not what she wanted. She wanted, and someone has called, don't have that on the slide, but it may be a term that you want to remember. Someone has called that skin hunger. So what she really needs was being able to touch her son and her daughter. That's what some people call skin hunger. She really missed touching them, because their conversations were not that well possible anymore. The only thing she lived by was skin hunger, was touching there. Now then, she said, I'm so lonely, I want to take the risk of infection to allow my son and daughter to come and visit me. So that was a problem for the nursing home that she was living in. Should they allow her to see her sons and daughters, or should they not allow this? I would, if we were in a physical environment now, I would ask you for your opinion. Should it be allowed? Should Mrs. A have her son and daughter around because she says I want to take the risk, even if I die earlier. I miss them so much that I want that. So her quality of life was so bad that she wanted this. Is there any student who has an idea, or any of the attendants, even the staff, who has an idea about this?
Yes,
So you can...
anyone can share? Silahkan, monggo.
Yes,
All right.
I am. Yes. Excuse me.
Yes, please.
Okay. Let me introduce myself. My name is Ivan Aryaguna. So basically, in my opinion, that if just in case that the Mr. A is increasing lonely, I prefer to take the who's Miss A relatives to take to live together with Miss A, because I think that if the Miss A is really lonely, it makes her Alzheimer could be worse.
Yeah, it's a good point. I think the fact that she is so bad may make her even is really making her quality of life and her Alzheimer worse. So what you say, in fact, is what you should do is let them live together. So one of the possibilities, of course, would be that she's moving out of the nursing home and goes to live with her son or daughter, and then they can take care of her. That would be a possibility. The problem here is that both the son and the daughter have very busy work schedules, and they feel that they can't take care of their mother, who really needs a lot of care at their home. So for the son and the daughter, that would be a bit difficult. What they said, the son and the daughter, was we can take her for a week, but then we really need to be able to bring her back for a few days and then take her again. And then the nursing home there said, that's no possibility. If you take her out of the nursing home, then she can't come back because she becomes a risk for the other inhabitants of the nursing home. So in fact, that's where you see the problem, where the individual care for Mrs. A would mean that she would be able to go to her son and daughter and come back. But because you have to take into account the population of the nursing home, that is what counts most for the nursing home now. So that this possibility of bringing her home and then taking her back which they normally would have found perfect and had no problem with, in the Corona period, they didn't want to do that. So the only possibility would be to allow the son and the daughter in the nursing home because Mrs. A wants it. But I don't know what you think about that, but this also may be a problem, because bringing the son and daughter in means also may mean bringing more risk of Corona into the nursing home. So here again, the nursing home didn't want the son and the daughter to come in, even though Mrs. A absolutely wanted them to come in, even if she would die earlier from that, even if she would get the Corona infection. So finally, that was the decision that was taken. And in fact, it was no. The answer was no, which was really sad for Mrs. A. Mrs. A comes back in the lecture a bit later. So this is the first ethical issue with distancing, because this is a form, of course, of keeping distance. And I thought I had an image. Yeah. So in fact, the only communication that they could have that Mrs. A could have with her son and daughter was through this type of image. So through this type of communication. So that's the first example that I'd like to. The next one, I think that we have to think about more, and we're actually finding out how to do those things, is that distancing leads to a rapid digitalization of care. So care becomes more and more digital in a very rapid way. We were already doing that at some points, but it was now really becoming the normal way of delivering care, both from the hospital and from general practice and in home care. So there's an increasing amount of video consultations. And one of the things that happened was, just as you are following, I hope still following this lecture from home, many doctors also started doing video consultations from their homes. And that actually leads to other ethical questions that we had never been confronted with before. So what about doctors' family members running through the screen? I think I saw some of the children of staff members and for a lecture, that's really no problem, of course. But for a consultation with a patient, that may be a problem. One of the surgeons in the AMC who raised this issue said she was working from home next to her husband, who is in banking or some other area. And then she was doing consultations with patients with him next to her, which is a real problem regarding the privacy of patients. So that was the first thing that becomes difficult. And also on the side of the patient, what we don't often think about that, but we think that that it's very important for patients to be able to speak freely to their doctors, even if they want to say something their other family members are not supposed to hear. So they should be able to speak freely. And we don't know if a patient is speaking with the doctor over a video connection, if there's not a lot of family members around who can interfere, or who may make it more difficult for the patient to speak out freely about their complaints and about what they're worried about. So that's another issue. Another issue that the surgeon mentioned that I was speaking with is it ethical to ask patients to undress or partly undress in front of a camera so that it can be seen by the doctor, but also so maybe by other people in the home of the doctors. So, and that this surgeon felt this was a real issue. To what extent can you ask patients to undress before a camera? And the last ethical issue that comes up is the recording of consultations. We have that a lot in our country, and probably also in Indonesia, where patients have their phones and can record consultations. But they may also be able to record video consultations completely. So it's with image and everything. And then there's obviously an issue with the privacy of the doctor there, because a recorded consultation may go viral on the internet if you're very unlucky as a doctor. So how do you prevent patients from recording consultations and then spreading them, especially if they're not satisfied with the doctor? This may be an extra problem, which there's extra possibilities to do this. So these are the things that we're going to do a project on, addressing these ethical issues, to develop guidelines about video consultations for medical doctors, and especially for doctors doing those consultations from the home. There's one other issue, which is the issue of patients who are unable, who are not competent enough with digital techniques to do a video consultation with. So how should you deal with the patient who is not completely able? For instance, a patient like Mrs. A that I was talking about previously, who has Alzheimer's, and is it possible to do a video consultation with her? So those I think are the ethical issues related to this form of distance that has been necessary and is still necessary for the corona epidemic. The last form of distancing, of course, is the most serious form, and that's isolation. I have a case that occurred in one of the general practices of one of the GPs that I work with. So one of the family physicians I work with, and it's about a couple that had been traveling from a risk area. I think it was Italy that was a risk area, especially in April. It's the first country where corona really hit it hard in April. And one of the GPs had a couple that had been traveling from Italy, and the couple fell ill after returning home, and they were tested for the coronavirus, and both tested positive. And they were not very ill. They were mildly, just having mild symptoms. And the policy at the time was that they had to be isolated at their home for 14 days. And in fact, in the Netherlands, I'm not sure how it is in Indonesia. We might talk about that, but the isolation at home is not seriously monitored. So people are just expected to do this for 14 days. And now what happened is that the man of the couple was without complaints after 2 days. His symptoms were really over after 2 days. And he was very nervous because after he had a company of his own, he's a businessman. And after 12 days of isolation, he needed to go to an important negotiation where he wanted to sell his business. And he said, I can't do that through internet. It's so important that I'm there. It may cost me an enormous amount of money if I have to do that over the internet. So he asks his family physician if he can go, and he promises to wear a mouth mask, to keep two meters of distance, even more than the 1.5 meters that we're used to in Holland. And the question is, should he be allowed to go to that meeting as an exception, or should he still stay for the last 2 days of his isolation at home? Does any of the students have a view about this? Should we be strict, or should we be less strict in this? And should the GP allow him to go as far as he can? Is there any student who wants to react either through Q&A or typing things or saying things?
Excuse me?
Yes.
Excuse me. I think that's this is a very ethical issues, and I think this is a dilemma especially for the man. If the man, so basically he has a important business things to do, but the other side is the man has to isolate himself 14 days at home. Is like,
yes,
it's just really important. Obviously it's very important. I see that there's a kind of dilemma issues in this case, I guess, which the both things are very important to be in my opinion. It's very important.
yes,
yes, I see. Yeah, so in my opinion, this is something what I call as a dilemma, is especially
Yeah, you're quite right. This is a real dilemma where you have a conflict of obligations,
Yes.
as we call it often. So there's a conflict between two things that are very important, but that you can't do at the same time. And you know, what makes this dilemma so difficult is that the isolation is something that he doesn't do for himself. You know, the patient has no interest in the isolation. He will not improve faster. He already has no complaints, and he's doing the isolation completely for the other people. And that's what I said in the beginning. The focus is not anymore completely on the individual patient, but on the population. So the isolation is really for the population, and it's not really in his own interest. So for him, it's really very difficult to stay at home where he has such important things to do. And he says, I'm going to protect the population by wearing a mouth mask and keeping a really big distance. So this GP, in fact, has said to him that he has explained the dilemma, and he said to him, you need to stay in isolation. So please do it through the internet. Now, there was another complication that's not on the slide, which is that during that time, there was discussion about whether 14 days was really necessary. I don't know what the rule is in Indonesia now. Could you tell me what the rule is for isolation in Indonesia? How long do positive people have to stay in isolation?
Excuse me.
Yes.
Indonesia is the policy is the same. It's a 14-day isolation at home.
Okay.
It's
Is it still 14 days? Because in Holland we changed. There was a lot of discussion, and it has changed. I think a month ago, the government has changed that into 10 days.
Yes, yes, indeed. There's a less revisions of the protocol of the person who diagnosed positive with COVID-19. That from the diagnosis, it only need 10 days before they can.
Okay. So it's the same. And the problem was, in the beginning, we just didn't know. It was so much was unknown about Corona that 14 days was taken as a better safe than sorry way of deciding. But then it was discovered that it's maybe too long. And one of the big ethical issues in the beginning of the Corona epidemic was of course that you had to take quite drastic decisions about people without much knowledge, because we just didn't know what the behavior of COVID-19 would be. So this type of decision, 14 days, wasn't based on firm evidence. It was based on the idea that you had to be better safe than sorry, but there was no firm evidence. So that's what this man also understood. That he said, I have to stay at home because you have decided 14 days, but there's no evidence for 14 days. So what happened finally is that he did go to his meeting. Because the GP couldn't keep him from the family doctor is no policeman, so he couldn't arrest him. So he went there and had a mouth mask, and I think finally he warned the other people that he had tested positive 12 days ago, and so they arranged the meeting in a way that there was really no danger of infection. So, and these are questions about proportionality mainly. So, is it proportional to be? Is it appropriate to be very strict in the 14 days, even if you don't have a lot of evidence? And so maybe it becomes too heavy then. So this is what happened in this case, but it does raise ethical issues, and it would have been a more serious ethical issue if this man would have said after 6 days or after 4 days that he needed to go to this meeting. also for the other meeting partners, of course. So that was a case that. So this was the first part of the first of the 5. So I will be going a bit quicker because otherwise you'll have the whole evening even with me. Are there any questions? Because I'm not going to speak about the ethics of isolation and distance any longer in the lecture. So if there's anyone who wants to comment or has a question about this particular issue, then please go ahead. You can do it through Q&A. I see that nobody's typing. Just start typing, and it's really no if you want that. So I'll just wait if there's any questions or remarks. Are you still keeping up? Are you still coping with it?
Yes, it's clear.
Is it clear?
Yes, and I don't think you're going too
Yes,
fast.
sir.
I don't know about the students, but
Sorry. So what did you say, Maria?
no, I don't think you're going too fast, and I think
All right.
you're quite clear. But
No, I think I'm going too slow, but I'll go a little bit faster in some of the issues. Okay, then I'll go on for the next one, and that is, I don't know if you've had this problem like we had it in Holland, but what happened was that that we discovered that there was obviously mortality among COVID patients. We have about 5,000 to 6,000 COVID patients who have died during the first wave of the epidemic, let's say from March to now, which is not an unusual number of people dying from viral infections if there's an epidemic of influenza or another virus in the Netherlands. But what we discovered was that almost as many non-COVID patients died during this period. So people with cancer, COPD, other types of chronic disease, and this was so a lot more than usual. So there was a surplus mortality among non-COVID patients. And this was partly due to the closure of outpatient clinics and of operation theaters, etc. But also, and that was a very important reason too, I think, because why there has been a surplus mortality, which may go on for quite a long time, is that patients were afraid to go to hospital. So there was it's clear that there has been quite a big diagnostic and therapeutic delay because of the fact that patients didn't dare to go to hospital and waited at home. And I'm sure this must have happened in Indonesia as well. And we know that has led to about 4,000 or 5,000 extra mortality among patients who did not have the corona infection. There were also indications that there was an increase among psychiatric patients in suicide, and that was probably due to the fact that they had to live in isolation, which for people with a severe depression was even harder. So the question here, and that's a very brief. Sorry, I didn't hear you.
hello, anyone wanted to ask something, or was it just an accident? I think it was an accident.
It could have been an accident.
Yeah. Okay. Please continue.
So the question that is raised now in Holland is if it is ethical to scale down, so to decrease regular care if there will be, and we're all afraid that there will be a second wave. It may already be preparing, because the last couple of weeks, I think, like in Indonesia, we're witnessing a new increase in infection rate. So the question is, are we going to scale down regular care again if a new big wave of corona care comes up. Does any of you and does any of the students have an idea of if we should do that, and if not, why not? And or is it something that we just have to accept as part of the epidemic, that it also hits people who don't have the disease? What do you think about this? Should we scale down regular care if there's a new wave of corona care?
Excuse me.
Yes.
So in my opinion, yes, actually this is again, I face the issues, dilemma issues again. I guess there's this is the dilemma issues, but I think the name of the beneficence, I think if the personality, I think the amount of the person, among the medical workers is still occupied and is still able to occupy. Able to handle that the scale of the regular care. I think it's okay, but if we're speaking about the shortage of the medical workers, especially in the developing countries, Indonesia, for example, I think in the name of the beneficence, it's very ethical for me to scale down the regular care, because
Okay.
I think the COVID is very important. Patients with the COVID is important for me. Thank you.
Yes, thank you very much. So you say we should do that if there comes a second wave. Sorry, if there comes a second wave, we really need to do this again. I'd like to hear someone with maybe someone with a different view. You can ask your questions in Bahasa Indonesia, and then they will be translated for me. So don't hesitate if you prefer to speak in Bahasa Indonesia, please. Does anyone have a different view or have remarks about this issue? You can also type it in the Q&A.
Ya, silahkan adik-adik, anyone from the students or maybe from the teachers, maybe also.
Yes.
Bu Meli, can I say something? Dick, I want to
Yes.
recently I heard an issue about the so-called non-COVID patient that died, and the medical practitioner or system say that they have to bury the body using the COVID protocol, and some of the family say they're concerned about that. They say that my family is not like a COVID patients, and they deserve the proper burial, which is not wrapped into with plastic, and in some area in Indonesia, due to the pandemic, they make a special funeral places just for the COVID patient. But some of the COVID non-COVID patients say that that their family say that they feel sad about the family that buried in using the protocol from COVID. What do you think about that?
Yes. I think it's an important question, because here again it seems like if the rules about burying are not applicable to people who don't have COVID, and it may mean that family members cannot say farewell to their loved one in the way that they wanted, so that is a burden to them. And I think really that if it's sure that the patient did not have COVID, then I can't imagine why you should follow the protocol for COVID burials. apart from maybe practical reasons that it becomes very difficult, and of some patients, you will probably not know if they had COVID or not. So I think the reason to demand a COVID protocol, even in cases where patients were not tested positive, is that they may still have had a COVID infection that you didn't know about because they didn't have symptoms, or they had it just started. So that I think is the dilemma here. So do you want to allow families to say farewell in a proper way to their loved one, even if there's a very, very small risk that that patient had COVID that you didn't know, or do you want to be so sure that no infection is transmitted during burial, that even in those cases you follow the strict protocol? But my view would be that I think here it's a bit disproportional to apply the COVID protocol even to those who had no signs or symptoms of COVID, and especially, of course, if they had tested negative. But that's probably not the case in most of the patients, because they had no symptoms. They will probably not have been tested. So that would be my answer. I think I think it's not proportional to keep on to the protocol. So I would hope that it's possible to bury non-COVID patients in the normal way. Is that an answer to your question?
Yeah. Yes, thank you.
Okay. So then I'll go on to my next issue, and that's the main part, and that's about shortages. And I'm really aware that we have had shortages in the Netherlands, and they're probably much worse in Indonesia. But it was maybe the first time in many years that there were so big shortages of different kinds in the Netherlands during this epidemic. And I think there are in fact now 3 things that were where there was a shortage in the months that lay in the months from the beginning of the outbreak until now. And the first important shortage was about protection materials for both professionals and families. And the ethical issue that came up in the beginning, when there were not enough mouth caps and there was not enough protective material at all, the first issue that came up is who should get the protective materials. So that's, I think, the first ethical issue. I'll say a little bit more about that. And then there's also a shortage, and there still is a shortage in the Netherlands, in testing materials and in laboratory capacity. So not everybody who wants or who needs to be tested can be tested. And it's partly because there's not enough testing material. It's mainly because the laboratories are not big enough to test everybody. So people now sometimes have to wait to be tested for 2 or 3 days. And during that time, they're not allowed to go to work because they have to stay home if they have symptoms, and they will have to wait for the results of the test for 2 days. So that means that if they get symptoms, many people have to stay at home for about 5 days. And the result of the test usually is that they don't have COVID. So then they will have stayed at home for 5 days without having the corona infection, which obviously is an ethical issue. And then the last and most publicly discussed issue was the shortage of hospital beds, and especially intensive care units beds. We didn't have a real shortage of regular hospital beds, but there was a big problem coming up in half April, about intensive care unit beds. In the future, there may, if a vaccine will be developed, or really effective treatments will come along, then there may also be discussions about shortage of vaccine or of treatment. So then you will have the question, who will get the vaccine or who will get the treatment? So these are the three things that I'll briefly say a little bit about. The testing material. So who needs to test first if the capacity is limited? Is that doctors or is it nurses? Is it the police? I'm not sure who would think politicians would be the first to test. Many politicians are not that popular in the Netherlands, so there are few people who would say politicians, I think. But so that would be a question. Who would need to test first if the capacity is limited? Does any one of you have a view on who would have the first would need, if there's 2 or 3 people who need to be tested, who would be the first to have to be tested?
Excuse me.
Yes. Is it? I can't see you. Yeah, you're. That's really interesting that you're so. You're the same person, I think, asking the question.
Okay.
That's
so,
very good.
Okay, so I think, in my opinion, of course, the doctor and the nurses. Why? Because in my opinion, both are the important. They are the frontliners of this pandemic of the COVID-19.
Yes.
In my opinion.
Yes. Do you have anyone else apart from doctors or nurses?
The doctor and the nurses, then the high risk, the patients with the high risk, especially among the elderly, with the chronic disease. I think that's the first priority, because these persons, these people is a very in a high risk to to infected by the corona.
Yes. And what would you also think of other people, such as, well, I mentioned the police, or let's say hospital cleaners, or people who do very useful work, even if they're not doctors or nurses?
I think that's but when it comes to others, I think it must be there's some regulations in some countries. I think it's been in my opinion, but for those the exceptional, for the doctor, nurses, the high risk elderly with chronic disease, chronic disease, the except all those trees, I think that's it's still become a dilemma. I thought I think this will become a dilemma. Who's thinks of first? But it depends. Some country, the policy of countries, how to manage it. Yes.
Okay. Yeah. So we in the Netherlands, we decided that there are some crucial professions that need to be tested first, and among them are teachers also. So because otherwise they will, so otherwise whole classes are dependent on them, and if they can't be tested, then they have to stay at home maybe much longer than needed. So teachers are among these crucial professions as well, and policemen too, because you also don't want policemen to stay at home if it's not really necessary. So that's the ethical justification of giving priority about testing, has to do especially with the problem that you don't want to let people have to stay at home if it's not necessary. So unnecessary isolation is in fact what you want to avoid by testing people.
Dick.
So,
hello. Excuse me.
Yes, please.
Yeah. So I think talking about those kind of unnecessary isolation, this is also maybe related to the society in Indonesia who are thinking that COVID is actually just a conspiration and stuff. And there are one of our students that would like to express her opinion. So Nahwa Aulia, you have already typed in the comment section. Can you tell to us directly about your opinion regarding to this?
Ya, Nahwa Aulia, silahkan. Can you unmute your mic, or would you like to answer directly, Dick? Can you read the chat, the question, her question?
I don't see any question in the Q&A.
Oh, okay.
It's on the chat section, Dick.
But I don't have a chat section.
Oh.
I see. That's
Okay.
interesting.
Yeah, it's really interesting. Maybe I missed a lot because I don't have a chat section. I don't know. I can see what I can do. Do I open the chat? No, I don't have chat here.
Okay, Nahwa, you can say it.
Okay, sir. Firstly, I want to ask you about what your opinion about the citizen of Indonesia, because they're less of discipline about the health protocol, especially for COVID-19, because they're so difficult to follow the rules that like wearing a mask during in public, and they're thinking that the COVID it's still the government, the part of the government conspiration, and
Yes.
and what shall we do as a part of the, what can I say, the one
ethics committee.
who in the front line. Just
Thank you, Nahwa.
Yes. Thank you very much for the question. We have also a lot of citizens who think that the whole COVID epidemic is a conspiration to increase the power of the government, because the government has issued regulations that that didn't even have to pass Parliament because of the urgency of the corona pandemic, and that led to, for many people who are very suspicious of politicians, said that it was just a conspiration to increase their power, which yes, well, I think the only thing you can do against that, because I really think they have to be very careful about that. So politicians should involve Parliament and citizens as much as possible and not do things on their own. But I don't think, apart from that this is true. So the only thing you can do, I think, is inform people and make them keep informing people about the real issues around the corona pandemic, which and that's the only thing you can do. So keep telling them that there's not a conspiracy behind it, but that there's a real viral infection threatening a lot of people, and especially the more vulnerable people in society. But what a government should do, I think, is be as open and transparent as possible about what they're doing, and not giving the impression that they're abusing the power in relation to this corona pandemic. And giving information, and that's, I think, also an obligation, an ethical obligation for doctors. And you know, one of the problems with the corona pandemic, as I already said, is that it was so difficult because in the beginning, so little was known about the virus, so there was a lot of insecurity, and so regulations have changed all the time, and that makes people suspicious. And the only thing you can do as doctors is inform them about the medical part of the corona infection. Okay, shall I'll go on to the next issue if I can.
Yes,
Somehow
please.
Yes.
Thank you, Dick, for the discussion.
And yes, all right. So what I'd like to discuss in maybe the last part of the lecture, I'll have a few other things, but then this is I think a thing to really think about, is the problem of a lack of hospital beds or intensive care beds, which, as I said, is probably more serious in Indonesia than in Holland, but it was serious at least at the beginning of April in Holland, because the Netherlands have less intensive care beds per 100,000 people than many European countries. And that is mainly because doctors admit only those patients to intensive care units who they think will benefit from it. So who will come out better than they went in and who will survive intensive care units. So usually this lower number of intensive care unit beds is enough. But in April 2020, there was a threat of absolute shortage of intensive care unit beds, which meant, and that's the really big ethical issue that doctors were very disturbed about, is that they would have to refuse patients who could be saved. So doctors, I think, are in Holland especially are very good at making good indications for intensive care units care. So if a patient doesn't have an interest to be admitted, they will not admit that patient. But in this case, it would be about patients who could be saved, but who would still have to die. So the problem in April was how can you choose who will have the bed if there's no medical criterion left? If you can't say this patient has a very small chance of survival, then you will not admit that patient. But what if both patients have a good chance of surviving and there's just one bed and they're both already in the hospital? How do you choose then? So let's return to Mrs. A, who I mentioned in the beginning of the lecture, who is 85 years old, who lives in a nursing home, has Alzheimer, but not very, very much, and various other diseases. So she, as you remember, she couldn't receive any more visits and is increasingly lonely. And then one day she gets ill and she's infected with COVID-19, probably by one of the healthcare workers in the nursing home who tested positive afterwards. So she probably was infected by this healthcare worker who didn't have any COVID complaints at the time she was infected. Now the question is, should Mrs. A, if it would be necessary to admit her to the intensive care unit, should she be admitted or not? I can't see the chats, but I'd like to have some views of students in the chats or through the microphone to tell me if they think this patient should be admitted or not to an ICU.
Okay, thank you, Dick. This is a very interesting question. Please, all students, don't be shy. We should be able to express our opinion. So maybe I would like to hear our friends from maybe like Lingua or Yahya or Hani, anyone?
Yeah, excuse me.
There is a question in the chat, Dr. Bagas.
Oh yeah.
Excuse me. From
But
Nafis
maybe,
Inayatul.
yep, but maybe we can focus on this ICU issue first before we go on to question from Nafis.
Yes, excuse me.
Okay, Ivan again. Please do share your opinion.
So this is Miss A with a slight Alzheimer. I think should she be excluded from the ICU? the question is really getting difficult for me. This, actually, yes, this is the most difficult questions, I guess. So she be excluded from the ICU, and I think that she has a nurses nurse to take care of her with her. I think that it's okay if she has Alzheimer. I think when to exclude it, when she has to exclude it from ICU or not, it depends to ask the nurse one or if you, or you can ask the Miss A if she still has the ability to think logically, to think logically and responsibly about the informed consent. I think that the doctor is to give the informed consent first to decide, to give the decision for the Miss A or the nurse or the nurse that which take care the Miss A to give the decision to exclude her from ICU or included her from ICU, I guess.
Okay, thank you. Is there any other idea about this? I'll come back to this because it's interesting, but is there any other student or staff member who has another idea about this?
Yeah, I think there are some GPs here, so maybe you can also give their opinion. Practitioners.
I think Ageng is here too as well. Hi Ageng. Or Miss Lily. She's also one of the COVID warrior in Unsud, I think.
Okay, yes, yeah.
Okay. Thank you for the time. For me, if this condition, maybe what I can say, it can be excluded from ICU, but we will see and can ask for the Mrs. A what she want. She wanna still in ICU with the protective intensive care of her body, or she will have a happiness with her family and around. So this can help to increase the condition. I think like that.
Yes. Okay. Thank you very much. I think both of you say, in fact, you should ask her and see what, if she's still able to think about this, then you should ask her what her view would be. And I think that's a really very good answer. But I think at the moment where she is admitted, it's panic. I mean, it's a hospital that gets flooded by COVID-19 patients, so you don't really have the time to inform if she still understands things, and she gets ill, very ill. So already the infection will prevent her from thinking clearly. So what we say in the Netherlands is that you should do this before you get so ill that you are not able anymore to take that decision. So what we've encouraged very much, and I think general practitioners, family physicians have played an enormously important role in that, is that they have spoken with their older patients, especially those who were really vulnerable, to see what they would want if they would get the COVID-19 infection. And then the result of that in most cases was that those patients said, please don't send me to the ICU, because they had heard and seen on television how terribly difficult the ICU stays for these patients are, especially COVID-19 patients, of course, had to stay for a long time in the intensive care units, sometimes 4 to 5 weeks, and which is a terrible thing to have to suffer. And they came out usually in a very, very bad condition. So most of the patients who were older than, let's say, 70 years or something were saying, I don't want that even if I get COVID-19. If I get it, then if I have to die, I have to die. There's some time when I have to die. But the essential thing is, I think that ethically speaking, these are things that you have to discuss in a period where they're still able to think about it. If their Alzheimer is not too bad, but then you have to talk with families about it. But do it before things get serious and there's no more time to discuss it, because then things may happen that nobody wants. In fact, what we have in the Netherlands, are there any more remarks, or can I go on?
Dick, I would like to ask you a question.
Yes.
So I read a little about this the policy that you have been discussing in the Netherlands about this, and until now it's difficult for me to imagine how it would be in Indonesia. I've discussed this with my husband, who I think is also here, and on Anton.
Oh yeah.
Also with my colleagues in bioethics department. I don't think we don't have here. I think maybe everyone here is thinking from their perspective as an Indonesian living in Indonesia.
Yes, of course.
So having this choice or regulation or guideline of choosing people who can be admitted or not is something I think is new. It's not we're not used to it because I think here people just go. We have the policy of who comes in is has the right to be there. But my question is, do doctors also take into account the family of patients, their decision or their request? Because here I think that plays a big role for doctors, for the doctor's decision on what to do. Thank you.
Yes. Okay. Thank you very much. You know, this kind of thing is new for us too in Holland. So it's not the case that people speak about this regularly, about this kind of choices regularly. So it was really in the context of COVID-19 that the idea came up that you have to speak with people about what they want. And so it's as new for us as for you probably, even though people may be more used to thinking about these issues. But I'm not sure about that. It was new for us too. So many family physicians had never done that before, but they felt that the threat of the COVID-19 epidemic, in fact, forced them to speak with older people about what they would want if they would get the infection. And yes, obviously the views of families are taken into account, but I think there may be a difference between Indonesia and the Netherlands with regard to the role of the family, because I think the Western countries and as the Netherlands are more focused on the individual and less on the family. So the regulations that we have are typically focus on Mrs. A and not on her son and her daughter. But in practice, of course, the son and the daughter would be present at such a conversation if they speak about these choices, and they would have their say, of course. And the doctor, I've done that as a GP for in some cases, and there was always a family member present, because I think you can't do it without the family. But there may be a difference in focus between Indonesia and here, because we finally think that it's the patient, the individual, who has the last word, and that may be different in Indonesia. So that is that an answer to your question?
Yes, it is. It is.
You have to involve the family, but the focus may be a bit different here from the way you do it in Indonesia.
Because I think
I'd like to.
Yeah.
You know, the problem here is that as you've had in Indonesia, no doubt, we had hospitals who were flooded by patients, so they all came in at the same time. So, and that is important to realize. there was no first come, first serve possibility, because they all came in practically at the same moment. So especially the hospitals in the south, and that was even stronger in Italy. The hospitals in the south had this, were really flooded by patients. So, and there would be no time at all to decide if there was a shortage of hospital beds. So the Dutch Association of Intensive Care Doctors made a protocol that could be used in these situations of flooding, of many patients at the same time, where you wouldn't have the time to speak for a long time or investigate people for a long time. So these are what I would call medical criteria to select patients. We call that triage, as in all kinds of disasters or war or on the battlefield. It's all called triage. And these criteria have been set up by doctors involving ethicists, but they're really medical criteria. And these criteria say that patients should be excluded from intensive care unit admission in the following cases. In case they have a less than 10% chance of survival. So you might think of people who have a very massive heart attack, or who have a recurrent heart attack, or patients who've been in a very severe car accident and who come to the intensive care unit and have a multi-organ failure and have a very small chance of survival. So those categories of patients, also maybe cancer patients with a very small chance of survival, they should be, according to these criteria of the intensive care, doctors be excluded from intensive care unit admission. Another separate category, and that category is more open for discussion, it's more debatable, is patients with very serious neurological damage. So patients who've had a very big cerebrovascular accident. They say here that they should be excluded from intensive care unit admission, even though they may have a higher chance of survival. So they may have a chance of 50% of surviving. But the criteria of the intensive care unit doctors say that very serious neurological damage would be a reason not to admit a patient in this COVID-19 period. And it may be different if there's no pandemic. Then they might even admit these patients. But during the pandemic, they don't want to admit patients with very serious neurological damage. And there's a discussion about this criterion. The other one is a patient who is in a terminal situation of disease, but that overlaps a bit with the 10% chance of survival, even though some terminal patients may, like terminal kidney failure or things like that, may survive for a longer time. But this is also an exclusion, a medical exclusion criteria. And the last one, and that's maybe the most interesting or the most ethically debatable criterion, is that you wouldn't admit very frail or very vulnerable patients, and those are the patients who would have a certain value on a frailty score, and that's an objective measure of frailty. And this is in Dutch. You don't have to read it, of course. It's just the images why I present this. So what these guidelines say is that you should exclude patients who are in a wheelchair, or who are bedridden, or who have a terminal disease. I already mentioned that, but so it's the wheelchair, and the discussion was about the question whether you also had to exclude people who can't walk without help, who are not in a wheelchair but need help to walk around. And the reason for excluding these patients is that their prognosis is probably very bad. So the expectation is that these people are so frail, so vulnerable, that they are not able to survive 3 or 4 weeks intensive care unit treatment. But there has been discussion about this group. I don't know if there's any of you who has any trouble with these medical exclusion criteria. Is there anyone in the chat or in the microphone who wants to say something about this? And
Excuse me.
Yes, please.
Excuse me, but in my opinion, I don't. It's I'm very interesting about the category of the exclusion from the ICU in case of things that is COVID things. The most interesting part is the very frail or the vulnerable.
Yes.
I think it's a really good idea. I think that's so. In my opinion, it's a really good idea since it's a really good idea for the individuals, but it's kind of bad idea for the people who hold the belief, who has the beliefs in the importance of the families. I guess it's kind of very a dilemma situation for the people who have the belief in the importance of the family, I guess. But it's a kind of good idea for the individuals.
Yes. So I think that's true. I mean, for families, it may be very, very difficult to accept that their family member is not admitted because they're frail, because they have to be in a wheelchair. And you must realize that these are criteria that will be applied even without informed consent. So if it is not possible to get consent from the patient, for instance, because the family is not there and the patient is unconscious or is not able to respond or is too ill to respond, then these criteria will be used, even if in some cases the family would not agree with it. And that makes it ethically very hard, but it may be justified by the fact that it's a real disaster situation. You have to imagine a hospital that is flooded by patients. So the discussion, I think I also agree with the fact that you use this frailty index if it says something about the prognosis of a patient. One of the ethical issues here is that the frailty index also sometimes applies to people with impairments, so who are not old and don't have diseases, but do need others for transportation. And those may be people who were born that way. So it has to be really for the group where it has prognostic value, and not for the group that has already lived like this for always, and that is prognostically not different from other people. So we were afraid that all people with impairments and handicaps would be excluded from ICU admission. And ethically, I think that's not justifiable. Now I make a next step to the really black scenario, because this is already terrible if you have to exclude people on these medical criteria, but there's still a medical justification. I'm now going to non-medical, and I'll explain to you. Well, it means that you have to imagine the situation that there are two patients coming to the hospital at the same time, and both of them have quite a good prognosis, but both of them have to be admitted to the intensive care unit, and there is just one bed. That's the basic situation that you have to think about. And what that situation is that there is no medical reason to choose between those two people, because they're both in a fairly good condition and they can survive intensive care admission. So that's what we call non-medical triage. And that was what was happening in April in the south of Holland. And we were expecting it to happen in the whole country. So that people who had a chance of surviving would have to be refused at the intensive care unit. Now, I think the basic ethical question here is, can we choose between those people, or do we have to have a lottery? Is it chance? Is it choice or chance? That's really the issue. And I can tell you about the situation in Italy, and that was the worst situation in Europe in April, where there were hospitals that decided to let every patient who came into the hospital draw a stick or draw a number that would indicate if they would have a right to ICU admission or not. And that was all patients. And they didn't know if they would ever need ICU admission, but they had to draw a number that would, and then it would indicate whether if they would need ICU admission, if they would get it or not. So the number of lots was the number of available beds. And they had many more patients. So that was a lottery. That was a lottery about the available beds. So this may be a bit complex, but this is about patients who are medically fit to go on the ICU. It's not about those who are too vulnerable or who have severe other diseases. This is about patients who are medically fit to go to the ICU, but there is a shortage of beds. There's not enough beds for everybody. And then the question is, can we still make a justifiable choice and let patient A go before patient B, or do we just have to throw numbers and let chance decide? So I've been on a committee asked by the Royal Dutch Medical Association with a few other ethicists to think about non-medical criteria for choosing between people. And that's a really difficult issue. And what we did is that we started from some basic values that we thought were important for everybody and shared also by most people. And these basic values are that every human being has equal worth or value. So there's no human being that has less value than another because of whatever reason. So every human being has the same worth. That was the first basic value. The second one is that the aim in the pandemic is to save as many lives as possible. It may be self-evident, but I'll come back to that aim. And the last basic value is the value of justice. And justice, it's important to realize, means that similar patients should be treated in a similar way. But so everybody who has a bad prognosis should be refused access to the ICU, and not only poor patients who have a bad prognosis, but similar patients should be treated in a similar way. But also different patients, dissimilar patients, should be treated differently. So if a patient has a worse prognosis than another one, then you should admit the person with the best prognosis and make a choice between those two. Now, we started by defining some criteria that we find unacceptable. So you still imagine the situation in which there are two patients, the simple situation in which there's two patients and there's just one bed. So then we say it's unacceptable to decide on ethnic grounds. So you can't say this person comes originally from Morocco, that person comes originally from the Netherlands, so we choose that's unacceptable. Gender is unacceptable. Religion is unacceptable. Quality of life before is unacceptable. So we don't accept that some people have a more difficult life, should not be accepted. The availability, the handicaps, also family relationships. So it's not acceptable that, ethically speaking, it's not acceptable that the family member of the doctor goes before another patient. Money is not acceptable as a criterion. So paying for access is not an ethically acceptable criterion for us. So that's what we specified in this protocol. The question, of course, but we can't discuss that, I think, for long, is that it's very hard to demand impartiality from doctors. So if a doctor sees his daughter come in with a COVID infection and there's another patient and there's just one bed and both of them have a good prognosis, then it's really difficult to ask from the doctor to not choose his or her family member, I think. Is it still going on? Are you still, are there any remarks here? Because this is a difficult area, I think.
Yes.
So there may be remarks in the chat box if you want.
Yep. There are a few questions here regarding to a criteria. This is from Irfan Hafiz. Actually, he can speak by himself. Would you mind, Irfan?
Enggak dokter, mungkin saja.
Okay, so he's asking about how objective can we be to determine that the prognosis below 10% is actually should be excluded from the ICU, and how can we be so determined and be sure that he will be really have a low prognosis or something like that?
I think that's a really crucial question. And it's a question that has, what we have at the ICU are criteria to decide about the prognosis. So there are indications that are not 100% sure, and that's why it's such a good question. It always remains a statistical criterion. So if you have someone with a repeated heart attack that has lasted for, let's say, 4 or 5 minutes before resuscitation was undertaken, then you have a statistical value that says that this patient has a chance below 10% of surviving. But it's statistics. So there's always the possibility that this particular patient has a bigger chance. And that makes it, but I think that's a tragedy that we can't escape from. It's not completely objective. And it may be that you decide to refuse someone who would have had a chance. But the problem is that is not, that's the human tragedy. And ethics cannot solve the human tragedy that we have to take sometimes decisions, very often have to take decisions based on not completely sure knowledge. So we have knowledge, but it's not completely sure. But I thank you very much for the question, because it's important to realize that any decision that we take on this issue is always based on uncertain knowledge that is not rock solid. So thank you very much for the question. And my answer is that we do with the best we have. Were there other remarks, Bagas, or not?
Okay, actually there are a few other questions, but this may not be related directly to the criteria. Will it be okay, or should we postpone it to the end of the session?
Yes, I'd do that. I'll just keep for about 10 minutes to discuss those issues. That's a very good idea. I'll go a bit more quickly. So we've been discussing about unacceptable criteria, and these are, I hope for you, similar, but you may discuss about them. But then there are, I think we have 3 acceptable criteria to choose between 2 people who have a good prognosis. So still, you have to refuse someone, and then someone is going to die who could have been saved. That's essentially the terrible situation. The first one is that you expect a short admission time. So days instead of weeks. That would be the first criterion. If patient A, you expect that he or she will be off the intensive care units in a few days, then the other patient needs more weeks, then you will have to choose patient A. Then the other criterion is healthcare workers, and especially healthcare workers who could not protect themselves against COVID-19 in the first wave of the disease. And the last criterion, and that's the most debated in the Netherlands at least, is that we think it is justifiable to make a difference in generations. And it means that very young patients from 0 to 20 years go before some older patients, and those go before still older patients, etc. Which means that if you have a patient who is between 21 and 40, they will go before a patient between 60 and 80, even if they both have a good prognosis. And I'll very briefly say what the justification of these 3 things are. The short admission time is justified by the idea that you want to save as many lives as possible, and if this allows you to save more lives if you admit the person with a short admission, which also is not objective. It's also based on statistical knowledge, but you can make a prognosis. And then healthcare workers, the justification for priority for healthcare workers who could not protect themselves is that it's a reward for exceptional courage in combating the COVID-19 epidemic. And that's a usually accepted justification. And then the generational difference, the justification for that in our view is called fair innings, and it means that older generations have already had a more completed life than the younger generations. And that makes younger generations more entitled, have more right to a place on the intensive care units, even if there is no difference in prognosis. And this, as I say, has been debated a lot in Holland because it sounds like age discrimination. And maybe I should explain why it is not age discrimination. We don't say, and I think it's important to realize, this protocol doesn't say that people above 70 should never be admitted to the ICU during the pandemic. That is what some doctors say should happen, but we think that's not fair. Because some people above 70 have a good prognosis, and if there's not an absolute shortage, then they should be admitted. They should have a chance. So refusing people above a certain age would be age discrimination. But choosing the patient who is from a younger generation, we think is a fair way of doing things, is not discrimination, but is a fair because the older generation has already had a large part of their completed life. So that's a very difficult discussion. It's also been a discussion. I've been in newspapers and television shows trying to explain this last criterion. And if this doesn't make a difference, so if the 2 patients are similar on all these criteria, then the only thing you can do we think is lottery, is let chance decide. I'll leave this case, even though it's interesting, for now, because we can return to it and I'll leave the two other. The burnout of personnel, I think, is an important issue. Ethics of research too, but I'd like to reserve some time for the questions you had on the previous ones. So, Bagasiri, did you find any questions that are not strictly related to the patient selection issue?
Yes. This is some issues about the COVID-19, but this is more specific to Indonesian context, where we have some kind of a boarding school, an Islamic boarding school, or we call it as pondok pesantren.
Yes.
Yeah. So the question will be delivered by Nafis. If you like to deliver yourself. Hello Nafis, Inayatul.
Silakan Mbak Nafis. Masih ada tidak ya? Are you still there, Nafis? Otherwise, maybe Bagas can read it out. Or
Yes. Yes. Please.
So yeah. So the question is, where this Islamic boarding school is really crowded inside, and the healthcare protocol is not something easy to be implemented there. What do you think about this kind of schools? How they should behave in this pandemic? And the other question is from Hanif, but maybe we can answer the first question first.
Yes, yes. So that's a problem that's been debated a lot here too, because in the beginning of the pandemic, all schools were closed. I think the same thing happened in Indonesia, and then they gradually opened up, and in fact, all schools are open again now, and there's no more online teaching in schools. Only universities have online teaching now in our country, and obviously schools are crowded. And they should take into account the 1.5 meter rule that we have. And they do their best to do that, but it's obviously not possible to stay at a distance all the time. So the dilemma is between closing the school or allowing some extent of closer distance than 1.5 meters. And I think here again, what also plays a role is that for the students in the schools themselves, the infection may not be that disastrous. What they may do, of course, is get the infection and spread it, but for themselves, it's not terribly disastrous. It is bad probably for the teachers, more so. So what we have is that the distance between students and teachers is strictly kept. They're strict about the difference between teachers and students, but we do sometimes allow. We don't close schools down immediately when the 1.5 meters is not observed strictly all the time. That's in fact, it's a bit a sort of a vague in-between area where closing down is not a good scenario, and the 1.5 meter is maybe impossible to, but there's still a lot of pressure on keeping the distance. So that was the first question, maybe.
Okay, thank you so much, Dick. And the next question will be from Hanif Ashidik. Hanif, hello. Monggo, silakan Mas Hanif.
I can't hear him.
Positive case.
Sorry, I'm sorry. I think you have to repeat the question. I couldn't hear you in the beginning.
Yes. Sorry. Can you hear me?
Yes, I hear you perfectly now. Yes.
Okay. Thank you. As we know, in Indonesia has a large number of positive cases, and this condition will be. I think it will be difficult for the medical practitioner, and in this case, I will in some hospital, maybe they have only 2 or 3 people, and so they are overworked like that. Maybe some of them work 2,000 hours a day and maybe more of that. And how do you think you?
Okay, so about the first question, the rights of doctors to see their families and to be that's really good that you mentioned it. It's a subject that I didn't have time to address fully, but it's been one of the big concerns in Holland too, because the same thing happened. I mean, we have more doctors and more nurses probably, but the problem is similar. They also were overburdened with work during especially the first wave of the COVID-19 pandemic. And there was quite a lot of personnel who just couldn't manage to go on working. And that's, I think, a serious ethical problem. What happened, partly they were, what happened was that a lot of medical personnel that was working in different departments than the ICU and the COVID departments was also used for on the COVID departments. So even if they were not specifically trained in the specialty, they were employed on other departments. What we also did a lot was employ students, so medical students who were working as help in the very busy departments. And I think what we also did was we set up a helpline for medical doctors and nurses, because we realized, and that was also learned from Italy, that they were not only overburdened by the amount of work, but also by the terrible things they saw happening to patients who died from COVID-19 in the beginning. And especially because they witnessed patients who died in complete loneliness and who didn't have their family present, because in the beginning, the idea in the hospitals was that a family was not allowed in because they might bring the infection into the hospital, or they might take the infection out of the hospital and increase. So we did a few things. We got in more non-specialized personnel. We had this helpline, and the last thing we also did is that they had shorter shifts so that they could recover a little bit. And I think one of the main things that happened during the time after the first wave, people got less strict with the rules, and so the 1.5 meter was observed less strictly, and this was very hard to see for the personnel that had been overburdened and had really worked full time even without seeing their families. And what they saw was that people outside the hospital were getting less strict with the rules, and that for them made the stress even bigger. And I'm really afraid that if we get a second wave of COVID-19, that the personnel will be even less able to hold on and to do their work, which was extremely stressful in the first wave. So thank you for the question, and it's a concern. And I think doctors and nurses do have a right to have a normal life, even if they are involved in COVID care. Were there any other? Oh, you had a second question, but I don't remember, and there may be other questions as well.
Yes, there's I think maybe the last question, maybe, guys.
Yeah.
This is already 5 p.m. A question from Pak Joko. Are you still there, Pak Joko?
Yoko, Pak Yoko.
Pak Yoko.
Hello, Yoko.
Can you hear me?
Yeah. Yes, yes, I can hear you.
Too slow, too small, the volume.
No, it's okay. I can hear you quite well.
Okay, thank you. We are on the situation where the shortage just started because you know that the Jakarta, I think, and other 3 provinces now in very serious conditions. So we just start the situation just like Netherlands had in April. One issue that I want to raise is that today I read the newspapers that the Minister of Health we plan to deploy the internship doctors. I mean the just recently graduated as medical doctors, but not have the full registrations. They have to do the internship program, and they just try to use these internship doctors that to serve as doctors to support the shortage of the doctors for the patient of the COVID. What do you think about this plan, Dick? Because I think this is in my opinion, this is unethical because the internship doctor they don't have any choice because they have to finish the internship to get the full license and full registrations. And the second thing that they now even they're not currently paid by the government, but the salary is actually very low. So, so what do you think about this plan of our Ministry of Health?
Yes, well, this is a real this is again a real dilemma, of course, and the dilemma is I think it has different sides. One of them is that you can't expect internship doctors to have to deliver the same quality of care as fully licensed doctors. So you have to make sure that they can at least give appropriate care, basic care, but that there's still enough licensed doctors around to make sure that the quality of the care is not diminished. But I think, and that's I think a solvable issue. The issue of pressure is of course very difficult. And we've had the same here. I mean, there was a lot of pressure also on students and on co-assistants and on internship doctors to be available, and that's a really difficult problem. I think you can only justify that if the disaster is really, really big, and if there's no other possibility, then maybe it is acceptable to involve people who could help, because there's also the ethical principle that says that if you can help in an emergency situation, then you should help. So I'm also not very. I think it's difficult if people say I'm not going to do that because my salary is too low. In the face of an emergency situation, I think the Hippocratic Oath also says that if you can help, you have to help, even if your salary is too low. So I think it's difficult, and you should do it really prudently. But I don't think it's unethical to involve these people if the emergency is really getting out of hand, and that's what has happened in the Netherlands as well. So I don't know if you agree with me, Joko, but that would be my answer to your question.
Well, I think this is, I mean, like you said before, that if we still have other choices, then you should. I think we should choose a medical intern as a last resort. I think
that's true.
To help the American situation of COVID, and I think that must be a better choice in my opinion.
Yeah, no, I fully agree with that.
What I see from our government, it seems like they choose the easiest way. They choose the easiest way. They try to organize the one that under their arrangements to support that plan. That's something that it's maybe a little bit suspicious, but that's what I can see. My impression for this policy.
Yes, I fully agree with that. It should be a last resort, and one of the dangers of the whole situation politically is that governments do take the easiest decision and are not sufficiently controlled by parliaments or public opinion, because it's a sort of a period in which they take all kinds of decisions, the emergency situation. So I fully agree with you. Yes, sure. And that's a role for doctors to keep stressing that issue, I think.
I think also the concern of interns or these students to, or yeah, these young doctors to have a say in what, or the choice in saying if they are willing to help or not. Do you think it's I mean, that's also an important thing?
Yeah, I think it remains important because students or young doctors may have very good reasons not to be involved in this.
Yeah.
For instance, if they have a vulnerable person in their home and they don't want to put that person under risk. So I think they may have good reasons, but I think they should have. They also should have good reasons. So you can't just say, I'm too lazy to do this, or I prefer to play football. There is an obligation for young doctors and students to help if they can, but it's not an absolute obligation. So there can be good reasons not to do it, but they should be of this sort, that you have other people to take care of.
Yeah. Yeah, thank you. Okay, Dick, I know the time is up. We have.
I understand. Yes.
Yeah, but there's one question. I don't know if do you still have time for that, or?
Yeah, or I can go on even for a bit longer, but depends on you. And I'll just put my conclusion. I won't read it. Just put my conclusion.
Okay.
Just
maybe just one more question from Yahya. I think Yahya, are you still there? You can ask, give your question briefly.
Here.
Yeah.
Okay. Prof, can you hear me?
Yes, I hear you. It's a miracle, but I can hear you.
Okay. I would like to consult about a case which happened to my community, which in Indonesia, if COVID-19 patients has established the diagnosis of COVID-19, they will be do the tracing. The tracing means like they have to listing the people who are contacted with for the past 14 days. And what I want to ask to you is the listing system and the tracing system who are made by human is still free for human error, which I'm one of the victims of tracing error actually. And
oh, are you?
yes, I am. And some of the people who are listed in 7th or maybe 8 days after the diagnosis are established, and by that, if the paradigm is already switching from personal care or individual care into population care based to making decision, is it able for us to inform the people who are actively or positively patients with COVID-19 to make people who are contacted with her or him knowing their self that I'm one of the contact, to make them take an action step for early diagnosis, because I don't know which one is more important right now in this case, is the privacy of the patients or the people who are contacted with to make them take an early diagnosis. Thank you, Prof. Dick.
Well, thank you for the question. Again, this is a very good example of how we now, because of this paradigm switch, it's really good that you mention it again. We have abandoned to some extent the traditional and the normal protections of privacy to be able to trace people who may be infected so that they can be isolated and not spread the infection further. And I think it would be very good if that would be left to patients themselves, and if people who have been tested positive would talk to those they've been in contact with. So I would prefer that very much, but I think it would be a way that introduces even more uncertainty and even more individual difference in the extent to which people have the courage to contact others, because as I've been told, it's not only in Indonesia, there's also quite a lot of stigma around the people who have been tested positive. So they may not be that willing to contact other people. So yes, I agree with you that it would be a very good idea, but I doubt if the other aim, which is to limit the epidemics, would not have to be sacrificed then. And I think that would be the real choice, the real dilemma. I don't know if that, and I'll end with that. We have had a discussion about what's called the Corona app in Holland, and the Corona app was designed as an automatic tracing device, in which people it would if enough people have that, they tried it out in Singapore, I think, and if enough people have that app on their phone, then they will automatically register the people that they've been in contact with through the phones that they have been in proximity with, and that would allow for, if everybody has it, it would allow for a lot more efficient training, but it would be almost entirely out of the informed consent of the people who are involved. So that's even a more where you lose concerns of privacy even more, I think. But that's an interesting discussion. I didn't have time to go into that, but that's another ethical issue. So maybe this was it. I'm not sure, Amalia or Bagas.
Okay, thank you so much.
Yes, thank you very much, Dick, for the to answer the question. Yahya also for the excellent question. Yeah, I think time is up for us. We literally did a 2 hours, Dick.
Well, yes, I was afraid of the 2 hours, but
yeah,
it wasn't difficult. It wasn't even difficult.
Yeah, that's good.
I think, and many participants even managed to manage the 2 hours, I think, too. I don't know what I'm doing. I tried to, oh yes, I tried to stop the sharing.
Yeah, I think this is an interesting topic for all of us, especially for doctors and medical students. That's why, yeah, I think there should be might be more and more questions, but yeah, maybe we'll have another session with you, hopefully in the next month or something.
I would be very prepared, and if there's anything that you think I could also answer, if you have questions in the chat box that you think would be worthwhile to answer, I'd be very happy to do that.
Yeah.
So if you could we could do that through email or through other, if you want.
Yeah.
And I would be happy to have. Oh, now I see my chat box. It's interesting. It disappears when I share the screen. Now I see 7 views in the chat box. That's an interesting trick of Zoom to. It's probably strange, but well, anyway.
What we'd like to do with students is to let them send questions if they have any to us, and we can pass them to you if.
And I'd be very prepared. I'd be very prepared to give answers. And if you want another session, just let me know.
Okay. Thank you very much, Dick. I think we have to say goodbye for now.
Thank you for the occasion, and see you all very soon, I hope.
Yes.
And not very soon live maybe, but that will happen again next year, no doubt. Yeah.
Thank you very much. Yes.
It was a pleasure. Thanks. Okay, bye.
Thank you, everyone.
Bye.
For wonderful talk.
Terima kasih. Thank you very much. Bye.
Thank you. Bye.
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 Baik adik-adik, mahasiswa, mahasiswi, boleh silahkan mempersiapkan untuk CBT lagi. Selamat belajar semuanya.
Selamat belajar.
Selamat nguji, Bagas.
Terima kasih Bu Asti. Bu Meli, soalnya jangan lupa dikirim, Bu.
Oh, saya kirim ya. Iya, maaf. Oke, segera saya kirim. Siap.
Oke, sampai jumpa semuanya.
Si kecil mana tadi, Bagas?
Oh iya,
sebentar.
Ya. Adik-adik kalau ada pertanyaan silahkan ya, dikirim ke email kami. Silahkan, boleh. Terima kasih Bagas, Bu Woro, Bu Asti.
Terima kasih semua.
Ibu Meli dari pagi.
Iya.
Boyok ya.
Boyok.
Iya, Bu.
Bu.
Oke, kita akhiri ya.
Ya, terima kasih.
Terima kasih semuanya. Assalamualaikum.
Salam.